Good morning to this month's Washington Healthcare Facilities Community of Practice. My name is Ryan Cronk. I'm part of the Secretariat at UNC that hosts the Community of Practice. And we're really excited about our presentation today on hospital surface hygiene in Cambodia. We'll hear more about the speaker in just a second, but just a few announcements. For those of you that might not have seen the email, WHO and UNICEF are launching the global report on wash, waste, and electricity in healthcare facilities. They have a webinar that's coming up on September 24th. There is a QR code if you'd like to go ahead and scan that. We will also post the link to register in the chat. Please be sure to join that. It's going to be a great session in participation or in coordination with UNGA in New York later this month. I also want to announce the UNC Water and Health Conference. If you are planning on attending, please be sure to register. This year is really exciting. We had our highest ever interest in wash and healthcare facilities, so much so that we now have a wash and healthcare facilities track. We'll have 4 core side events and several others that are related to wash and healthcare facilities. WHO will also be presenting the new Global Progress Report in a side event with several other collaborators. We'll also have a consortium of faith-based organizations that'll be talking about how they're uniting for Washington healthcare, especially in our post-foreign aid environment. We'll also have a session that UNC is hosting with the World Bank on sustainable management models for Washington healthcare facility. And then we added a really exciting session on Wednesday afternoon on what's next for Washington healthcare facilities. We have several experts that will look back and look forward at what's happening in Washington healthcare facilities, and that'll be facilitated by Bruce Gordon at WHO and Ann Thomas at UNICEF. So we're really excited about that. There's a lot of exciting verbal presentations, and it's going to be a great opportunity for the community of practice to connect in person. So if you're planning on joining, please go ahead and sign up if you haven't. We'll be dropping the link in the chat for that. If you are unable to join in person, just yesterday was announced that we will continue with virtual participation and the ability to participate virtually in the conference. Many of the side events and many of the verbal presentations will be live cast on a Zoom webinar platform. So you will be able to watch the content. Participating may be a bit harder. Obviously, you'll miss out on all the great connecting networking time. But if you aren't able to make it in person, this is another great way to participate. And we will send out through the community of practice newsletter all of the sessions that are healthcare facilities related, so that you can plan if you're only gonna join those sessions. If you're planning on attending in person, we'd love to connect. Please feel free to drop your name in the chat that you're coming, so we can make sure that we know you'll be there, so we can make sure that you're plugged in with the rest of the crew that's coming. One of our standard announcements, we're always looking for feature projects. If you have a project or success story that you'd like to share, we have 2 newsletters, one that we host and one that WHO sends out on healthcare facilities, and we love to highlight ongoing projects and success stories, and we can help you sort of craft that for a newsletter format. So please drop any ideas you have in the chat, or feel free to email Darcy Anderson. Her email is posted. We're also always looking for new topics and ideas for upcoming webinars. We have several planned. We will hope to get into the rhythm this upcoming year with a pre-planned schedule, so that you know what's coming in the docket. So stay tuned for that. And with that, we are so excited today to have Dr. Georgia Gahn from the London School of Hygiene and Tropical Medicine. She's an assistant professor there and has probably been the leader in the Washington HCF space on cleaners. And so she's a really exciting trial that she's going to share on today on surface hygiene. As per our usual practice, we will have a Q&A at the end. If you have questions throughout, please feel free to drop them in the chat, and we'll triage those, and I'll ask those to Georgia. Once we get to the Q&A session. So with that, I will turn it over to Georgia. Thanks for joining us.
Thank you very much, Ryan. Just be sharing my slides. So today I'm going to talk to you about Clean Frontline, which was an exciting project, a big partnership between the National Institute of Public Health Cambodia, the District Health Services Cambodia, WaterAid, of course, the London School of Hygiene and Tropical Medicine, and funded by Who Gives a Crap and the Reckitt Global Hygiene Institute. So it's a big team, and of course, I'm representing the work that everybody has been doing over to achieve this trial. So before going into the specific of the trial, I kind of want to just tell you a little bit about our journey and how we kind of started this work around cleaners, which started over a decade ago when we were tasked with looking in several countries at hygiene in the maternity units. And very quickly, we realized that cleaners were a very, very neglected cadre. They were often older, female, and lacked any basic training on proper techniques for environmental hygiene in the hospital setting. Also, their contracts were often much poorer in terms of their condition compared to other health workers in the facility. So there was a series of socioeconomic characteristics and demographics that made them particularly vulnerable, not just in terms of providing patient safety, but also not being able to provide safety for the other health workers and themselves. So really briefly, this is an outline on how we progressed. Initially, we did a bunch of assessments of hygiene in hospitals using the Wash and Clean assessment tool in countries like India, Bangladesh, Zanzibar, and Ethiopia between 2013 and 2015. This kind of tool kind of fed into the Wash Fit tool, which I'm sure you all know about. And we've published a couple of articles trying to make the link between hygiene, health outcomes, and highlighting some of the issues around environmental hygiene specifically. Between 2015 and 2017, the Sobox Collaborative, the organization I was working for, decided to develop then a training guide for cleaners because there was such a big gap. This was a partnership between the Sobox Collaborative and NHS Grampian at the time, and it was first piloted in Gambia, India, and Myanmar. We took it forward in 2018 for a formal evaluation, was a pre-post design across 3 referral hospitals in Tanzania, and it was quite successful. We kind of doubled the level of microbiological cleanliness, at least in a pre-post design, which has a lot of biases. And this is why I'm talking to you about a trial today to try and strengthen the evidence around the effectiveness of this training. I want to also flag that, over the years, the issues of hospital environmental hygiene became more prominent. And finally, in between 2020 and 2021, we kind of had the chance to sort of feed into the cleaning indicators proposed by the Joint Monitoring Program. So this is a big deal because, of course, if you count it, you're going to pay attention to the issue. And between 2022, 2024, the WHO antimicrobial resistant unit and team decided to adapt the Teach Clean package as the official training for lower resource settings. And this is what we tested in Cambodia. So how does it look? So the training manual adapted by the WHO, it's available online, of course, and it was released in 2024. It's a great sort of resource available to everybody, so do feel free to sort of look it up. And there are 2 main documents. One is the modules and resources, which actually highlights the content. And then the other guideline is the trainer's guide, because actually this type of training is meant to be a training of trainers model. And I'll tell you a little bit more later. One thing I want to flag is that, today I'm talking about environmental hygiene, and you'll see a lot of the word environmental cleaning. I'm sure most of you know, being practitioners or researchers in this area, that cleaning is a very wide term. It includes decontamination, disinfection, dusting. It includes routine cleaning. It includes discharge cleaning. It includes high-risk area, low-risk area. And the reason why we're using these very broad terms in this case is because these documents highlight the appropriate technique and frequency for different actions according to the type of sort of cleaning is like this very wide term. So it depends on the type of task you have to do. You have to apply a different technique, different product, and this is why we're using such a wide term today. But these modules and these resources highlight what you have to do at what point for what type of risk in the hospital setting. So what are the key features of this training? Essentially, it's a train of trainers model. You train cleaning champions at the district or national level who go back to their facilities and train their peers. And this model was envisaged because it's technically low cost, and we're always thinking of a low resource setting. So the key thing about this training manual is the pedagogical techniques. They're targeting professional adults who cleaners are with low literacy capacity, which is most of the sort of profile that we encountered over our needs assessments, the early needs assessment over a decade ago. And what does that mean? It means that there are lots of participatory exercises, there is a lot of demonstration, there is a lot of practice, there is a lot of use of videos and other visual aids so that some of the concepts can be conveyed without the use of too much words and written material. So, for example, illustrated guidelines are a key component of the Teach Clean guidelines. So what are the content module? Of course, there is this cleaning, when to clean, how to clean, linen management, waste disposal, protective equipment wearing, an introduction to infection prevention control to convey the importance of environmental hygiene in achieving patient safety and reducing healthcare-associated infections. Of course, hand hygiene and personal hygiene. And then there are specific cleaning champions module, so for those who get trained first and then they have to train others, we have materials on how to train and how to supervise. There is also a focus on local adaptation, alignment with local policies and resources. And I can tell you a little bit more about what we did in Cambodia. So in Cambodia, we targeted district and provincial referral public hospitals across 3 provinces. So Kampong Chhnang, Battambang, and Krati. We included the whole hospital in terms of the training, but in terms of the evaluation, we focused on the pediatric, the maternity, and the general medicine wards. And so these are the key steps, the manuals, because it's not just a training guideline, it's a bit more than that. It's a program to try and improve environmental cleaning. So you have an initial assessment of the needs. Then the idea is to contextualize it, aligning with local guidelines and the local resources availability. Then the idea is to train the champions, these champions train the cleaners, and then there is supportive supervision. So this is the whole program set out in these WHO resources. So in terms of assessment and adaptation, actually, for example, one thing that Cambodia didn't have any guidelines on cleaning patient beds. So this was definitely added compared to the initial guidelines. But what we called master guides in Cambodia essentially put a huge effort in trying to align the national guidelines with the WHO package. And this meant in different things in terms of making sure that it aligns with the available equipment the cleaners have at their disposal, for example. This is actually a video on how to clean a blood spillage, because they didn't have any guidance prior to this in the country about blood spillage handling. And the whole alignment with local equipment and local practice is really important, because the idea of this has to be done to achieve realistic improvements. And so we put a lot of focus in making sure that it's feasible in the local context. So in terms of the training technique, just to give an idea of what we mean by participatory methods, as I said, we use adult learning techniques for teaching, like presentation with visualization, pictures, photos, videos that were also shared then with cleaners so they could re-watch them later. There was group discussions, paired work, brainstorming, demonstration, storytelling, and sharing experiences. Eventually, we trained 52 champions across the 13 referral hospitals. And eventually 271 participants were trained at the facilities. 51 were people dedicated to cleaning in the targeted wards, general medicine, pediatric, and maternity. So one thing that I really want to focus on is that often in a hospital with really low resources, you need to focus, you need to prioritize because you don't have the human resources to clean as much as you would want or have a cleaning schedule that it's ideal. You need to compromise and there are some trade-offs. And we definitely focused on high touch surfaces, which is also a concept I'm sure you're familiar with if you've worked on hand hygiene in the healthcare sector. And essentially, this is part of the patient zone where most of the transmission, which can compromise patient safety, happens. So, for example, I've circled some of the areas. This is a delivery bed where we would expect a lot of transmission to happen, in the vaginal area, where people put their hands, where there is body fluids transmission. In terms of supervision, there are many ways of doing supervision. We have observation checklists, part of the manual, but we also tested in Cambodia fluorescent gel, which is essentially a little product that you apply on a surface, and it can be easily removed with a wipe. And it's a really good supervision tool, not great for evaluation, but it's a great supervision tool because local champions could apply it and see if the next day has been removed with a torch which captures fluorescent material. I think the other thing that it's important is that we try to do realistic schedules, and I cannot emphasize this enough in the sense that we had an issue with human resources. There were very few cleaners in this hospital. They had very few hours available for cleaning. They usually had other jobs in the afternoon because they were so poorly paid in these hospitals. So I think it's really important that we had realistic discussion with the champions and the cleaners, trying to figure out what can realistically be done. How often can you clean the patient zone? So why did we do a trial? Why did you invest so much in trying to do a thorough evaluation of this? And essentially, the idea was, can the package be scaled up at the national level? And does it really show an improvement in microbiological cleanliness? And can these be sustained over a period of time? Because often, if you'll see many of the studies available in low and middle income countries around environmental hygiene last for a couple of months. We try to monitor the outcome for 10 months. And the idea is, should a government invest into it? Does it really improve microbiological cleanliness? And the only way you can really do this is by doing a randomized design that tells you, like the causal inference, the likelihood of causal inference of this intervention. So we ended up doing a step-wedge trial, which essentially means that all hospitals got the intervention within the study time. But what is randomized is the timing of when the hospital gets the intervention. And that allows us to talk about causal inference and say, probably the intervention did or didn't improve the environmental hygiene. And it's really important because the reason why we went for a step-wedge trial as opposed to a classic randomized trial is because it gave us data about time trends. And this is a really important thing in microbiological cleanliness. Things change. There is seasonality, water supply change, and therefore capturing that trends in time of the outcome was an important feature of the trial. And the other thing that is important is that it kind of simulated a national rollout because the country was kind of keen on taking this forwards if it was successful. So this is how it looks like. This is how the step-wedge trial looks. As you can see, there are 13 hospitals on the second column on the left. We collected 30 surface sample per hospital per month. We had two months of baseline. And the first round of training of trainers, so the initial part of the intervention, happened in July 2022, where 3 facilities received the training. And as I said, who went in sequence 1 or who went in sequence 2 or 3 or 4 were randomized. So the hospital only knew a few weeks in advance when they were receiving the training. So the training of trainers, so the training of champions happened in July, and then they went on and trained their peers in facilities the following month, so from August. So from August, we see the intervention happening at the facility for these three hospitals and the follow-up supervision until March when the training happened, the trial ended. And we continuously monitored microbiological cleanliness every month from May 2022 to March 2023. So concurrently, we assess not just the sort of hard outcomes like a microbiological cleanliness, but we also looked at process outcomes, which were really important. We had a qualitative researcher who did an amazing job, carried out observation of the trainings, had several interviews with cleaners and focus group discussion with stakeholders of the project to understand what worked and what didn't work. And some of the things that came up, and it didn't just come up here, qualitatively also came up in several countries where we did the piloting of this training. Cleaner said, the good thing is we can now classify the high and low touch places. Overall, I think the training is so useful and it makes us feel safer when we use what we learn from the training. And I think this is, again, interesting because it places cleaners in an important chain in the patient safety transmission route. I feel are more important for the hospital than before. If hospital don't have us, the hospital will be more contaminated. If they don't have us, the health will be more difficult. I think it's, for many people, was the first time that they realize I matter for health of patients. So it's a very, like, often, we talked about invisible cleaners at the beginning of the presentation, and it's empowering this cadre to make the most of their role to be able to ensure patient safety. But also there were issues. As I said, we had very few cleaners per hospital. They often had a second job, and they obviously had more tasks now because the technique is harder to achieve if you do it properly. Repurposing of cleaning material is harder if you do it properly. So they had to spend more time doing their tasks with the same pay and with the same number of hours. So what did we find in terms of the trial primary outcomes? What did we do was that we capture microbiological cleanliness in the patient area, which was either the bed, the patient bed, which could be the mattress or the bed frame, or area surrounding the patient bed, things like bedside lockers, for example. So every month, the team went to conduct this sampling, and the samples were brought back to a central laboratory where they were cultured and read. And we used these things called deep slides. They're extremely easy to use. They're double-sided. One side basically picks up anything, and one side was pathogen specific, and we looked at Staph aureus, which is a very typical pathogen when looking at environmental hygiene transmission. And in terms of bacterial growth, this is kind of the scale we used in terms of reading. You go from no growth to essentially complete growth at the right-hand side. And we considered clean according to standard procedure, anything which was less than 2.5 coliform units per centimeter square. Now, I'm going to show you the results. And the first thing I'm going to show you is actually the variability of the outcome by month per facility, just to give you a sense of what we found overall. So each graph represents one hospital, and the numbers at the bottom are the months. So from month 1 to month 10 of data collection. The red dotted line is the timing of the intervention. So when that facility received the intervention, so the cleaners or other people involved in environmental cleaning were trained for the first time. And what does it show you? It obviously seems very chaotic, but essentially that's the message. Microbiological cleanliness varies a huge amount, and that has huge implication when you're trying to evaluate whether something like a training or any program in environmental cleaning has worked or not on this outcome, because you need a big sample size. When something varies, means that you need a bigger number of either hospitals or samples to be able to really understand whether there is an effect. But it's also important to understand that because, it's not just the technique that will have an effect on your outcome. There are other things going on at the same time, and it's really important to take that into consideration. So overall, we had 3,900 samples. In the final analysis, 3,822 were taken into consideration. And we did find a positive effect of the intervention. So for those of you who love odds ratio, probably most of you don't, we had essentially over a 30% increase in microbiological cleanliness at the surface level. So on average, surfaces were 40% cleaner if after the intervention compared to the pre-intervention period. But much more intuitive is the hospital level average difference. Over this is an average at the hospital level, so it masks some of the variation. And it's to some extent modest. It means that on average, hospitals were 5% cleaner after the intervention compared to before. And I'm sure some of you are thinking, is this good enough? You said that I said earlier in Tanzania, we found that we had a double in microbiological cleanliness across 3 hospitals. Why are you only finding 5% here? And I think something I want to really make you think about is that actually most public health trials fail to show any effectiveness because when you actually randomize, and there are also other issues like trends of improvement in control groups and so on. But essentially the message is, given the challenges in the health system that we had, very poor leadership in environmental hygiene, very few staff with very few hours in their hands, their first ever training, champions who were already overloaded with many other tasks in their hospital work. And using a randomized control trial, which actually tells you A causes B, this is a great result. And especially together with the qualitative evidence that people like cleaners really improved their knowledge. They really felt much more empowered. And they were actually applying the correct technique. Another important feature to think about is that this was only about 5,000 USD per hospital. So really relatively low cost compared to most environmental program, let's say in a high income country. Now, the Cambodia government really wants to take this forward, and they're figuring out how to scale this up at the national level. And they've already started integrating these guidelines into their national guidelines and sort of updating their infection prevention guidelines to reflect this. So it's a great achievement compared to a few years ago where there were no guidelines on environmental cleaning in Cambodia. I think I want to flag that even though we didn't look at directly healthcare-associated infection, it's extremely hard to do this in low-resource settings because most hospitals do not have blood culture. So we cannot really assess whether it's truly a healthcare-associated infection. There is a lot of evidence of the link, well, I wouldn't say a lot, but there is substantial evidence of the link between microbiological cleanliness and healthcare-associated infection and cleaning and healthcare-associated infection. So by measuring something on the pathway, which is microbiological cleanliness, we can be confident that we're working towards the right direction. And of course, yesterday was World Patient Safety Day. So I just wanted to flag how, this is not just about cleanliness of surfaces. This means that environments are safer for patients and for staff. So for those of you who are interested in thinking about evaluating this type of training program, we've also developed an evaluation methodological guide that goes along with the training package that makes you think some of your options to try and evaluate whether the training worked in your context. And I also just want to finish saying that there is still quite a substantial unfinished research agenda around hospital cleaning. Last year, we published a commentary linked to the Clean Briefing paper, which highlights the research priorities still needed to strengthen environmental cleaning in healthcare facilities. And I think there is still quite a lot of work to do to be able to address this issue. There is a lot that can be done already in terms of implementation, but there is definitely still quite a few research questions that need to be addressed to help countries to move in the most cost-effective way. So I want to just say thank you so much for listening and to all the teams that collaborate to this project. And I'm really looking forward to your question.
Great. Thank you so much, Georgia. Please feel free to post your questions in the chat, or you can raise your hand and ask Georgia directly if you'd like. So I'll give everyone a minute to think of their questions. I'll start with one. I'd love to hear what your next steps are, and what the government of Cambodia is thinking of doing with these learnings.
Yeah, I think essentially, as mentioned, I think the big thing we're trying to include this into routine practice. And I think the biggest challenge is not the training per se, but actually keeping up the supervision, which is always something that we struggle in all area of quality of care in the healthcare sector. But it's a key part of making sure we not just change practice, but the practice is sustained. And I think this is something that I think we all need to focus on, essentially, how to sustain change over the longer period. This was over 10 months, but, we would be very happy to go back in 5 years and say, is this sustained over the longer term? And I think that's always much more of a challenge. I think in general, we've had a lot of experiences of this package being developed and being really well received in Africa and Southeast Asia, at least. And I think now it's got a life of its own. But I think it's reassuring to know that has the potential to actually be effective and cost effective.
Great, thanks. We had another question come in. What are the high-risk places in healthcare facilities, maybe in general, but or maybe in particular, the settings in which you were working?
Yeah. And I'm sure the audience is very varied, so I'm gonna say something very much in lay words. But essentially, the two things I always try and remember is the difference between the patient zone and the other areas of the environment and key transmission routes. When you think about high risk areas, it's always where the risk to pathogen transmission is highest. So of course, if you have anything to do with where areas where delicate equipment sits, anything will be in contact with the patient. This is how you can think about it. The closest to the patient, the most high risk it will be. So that's why we talk about, for example, the patient bed or equipment, like equipment trolleys, for example. The other thing to think about is the difference between body fluids and non-body fluids. Body fluids pose a lot of risk, right? I mean, obviously, etiologically, that's how it works. So I think that's a really important thing. So the difference between cleaning a blood spill or vomit is very different than cleaning a floor where people just step on. So I think these are the two distinctions I try always remember without going into too much detail, essentially, because there is obviously different techniques for different parts of the hospitals. And of course, then kind of linked to that, it's the type of ward. There are wards where you have very high risk patients and wards where are much lower risk. And that's kind of determined by the type of disease, the type of patients that you have. Obviously, some newborn wards are at different risk than an outpatient department. People with highly infectious diseases have usually a different location in the hospital than people with chronic diseases and so on.
Great. Lots of new questions coming in. Next one, with this approach, did you observe or learn anything interesting new with respect to hand washing by cleaners in the healthcare facilities? And sorry, I moved it too quickly. and about how to enable more consistent hand washing. So,
It's a great question, Jeff. Thanks so much. The Unfortunately, we couldn't look at systematically hand hygiene of cleaners in this study. We didn't have the resources to do that. But I think my biggest lesson in general in hand hygiene of any health workers is to make it as easy as possible for them to do it. And I've had quite a bit of success with personal hand hygiene bottles,
mhm.
literally like necklaces. And we've often like also tested it against common hand hygiene bottles. Um, One thing that health workers care about in terms of their intrinsic motivation is to not waste time because they have a lot of stuff to do. And I think hand hygiene can be, if appropriate for that kind of moment, it's much quicker than water and soap. And often many of these facilities, not necessarily in Cambodia, but in many lower resource countries, might have issues with water supply. So I think it gives you more consistency if you can get the hand hygiene supply right. And it can really help establishing a habit as close to the body as possible, if that availability is possible. So that would be and I think the other thing that often is not done with cleaners, but often also not with health workers, is to engage them in the concept of patient zone.
Mhm.
Often it's not talked about, even in the trainings that I've encountered. Explaining how important the patient zone is that if the minimum standard is wash your hands between one patient zone and the other, it's plenty already, even if you cannot follow the hygiene guidelines to perfection. And I think often engaging people in the training to explain the concept of patient zone and also define with them the patient zone. Because the patient, often people think patient zone is a set concept. It's not, because it depends on cleaning regimes, it depends on the type of patient, it depends on body fluid management. And that's a key concept. Engage with your audience on to defining the patient zone and understanding, can you at least do hand washing when you move from one patient zone to the next?
Great. Victoria had a question. Great to see the evidence on the efficacy of the package. Was cleaning supply or PPE access an issue in these facilities? And if so, how was that addressed? Did you find effective strategies for increasing institutional support for budgeting these supplies?
Yeah, so it's a really, really important question. So what we did is that we provided a minimum amount of supplies. And the biggest challenge probably was the number of cloths, because one of the key things is not use the same cloth in for different patient zones. So you need one cloth per patient zone, or maybe even more than one, but let's say minimum one. And the idea is that you fold it in eight and use one side of these eight folds per swipe. And that was one of the things that they definitely didn't have. They often had very few cloths. They had to repurpose them each day, which takes a while, especially if you don't have a washing machine, especially if you have to dry them properly. So that was definitely something we provided, cloths, enough cloth, which doesn't even have to be fancy cloth. It can just be, a big piece of cloth that you can cut in enough pieces for them to have enough of. In some cases, we provided buckets and boots, but it kind of really depended on the status of the facility. So we had a checklist of things we wanted there for the training and for the routine practice, which were like sort of the minimum standard. And then some facilities already had them, some facilities didn't, and we kind of provided ad hoc based on their needs. But we never provided something that was not already on their budget list. You see what I mean? This was like a top up about resources they already had available, rather than trying to reinvent the wheel with new equipment that they wouldn't have managed to keep sustainably in the long run.
Great, thanks. Silas asked, did the education level of the cleaners have any significance in your findings?
So the um so we trained different people. Among the 271, there were also nurses, there were also some managers, not very many. So obviously, depending on who you're training, in terms of both personality and education level and other characteristics, some concepts are picked up in a different way. But I would say because of how the training guidance is developed, which is based on really visual elements like videos, illustrated guidelines, demonstration, um, I think it gives the opportunity to everybody to engage. and everybody to be able to sustain their learning in the longer term. That's kind of the idea. It was meant for people with low literacy. Um, I I also think that often cleaners engage really well, sometimes even better than other cadres, because it's the first training they're ever invited to. So they feel empowered and excited. Usually people don't care about them. They don't put them in any training. So I think there is the advantage of the excitement that can really engage people for the first time in a very meaningful way.
Yeah, we've seen some of that in our work too. That's great. Darcy had a question. Since it mostly tackles individual level determinants of successful cleaning, do you have any thoughts on how it could be coupled with other systems level changes? What might that look like?
Yeah, I mean, that's the, $10 million question. Unfortunately, it is the same issue with other health system challenging. So I wouldn't say that it fundamentally changes in terms of trying to get things properly budgeted, properly cared for, properly on the priority list of the managers. I think the only thing that maybe is slightly different is that until very recently, and still so in many places, it's not considered an important aspect of patient safety. And I think more and more now there are more tools now that allows you to sort of estimate some of the economic impacts of doing good infection prevention and control in terms of the gains from the health system. And I think increasingly we can make a much better case for investing in infection prevention control, including environmental hygiene. So I think it doesn't fundamentally change in terms of how hard it is, but it's more about how do we make it something that managers want to prioritize. And I think definitely the economic argument is always one. So, and I know, Darcy, you know a lot about that, so I'm sure you can comment on that too.
Next question. Lots of great questions. Thanks everyone for jumping in here. So the next question is, what could be the ideal practice for proper disinfection and how regularly should it be done?
Yeah, so that really depends on the ward and the type of patients you have and the type of resources you have. So that's why I'm super, super, super. If there's one thing you're taking away from this, I really would like you to focus on the local adaptation aspect because unless you create realistic schedules given your resources and the type of wards you're dealing with, there is no point of having an ideal scenario. Some of the frequencies and the type of cleaning are included in the training guidelines material, so you're very welcome to look them up. But I cannot stress enough how much aiming for realistic is much more important because I guess you overwhelm people. You know, for example, champions in our hospital were worried about losing cleaners, that they would quit because there were too many tasks that were expected of them.
Next question. Did you also need to include training on waste management in order to address effective cleaning?
So waste management is a huge topic in the healthcare sector. There is a little bit to do with cleaning equipment in there, but it's not the main focus of the training. So I think it's only in relation to environmental hygiene, not in relation to overall waste management in a healthcare facility. Hope that answers the question.
Next question. Recognizing this intervention would be only one contributing factor to reducing infections. Did you track HAIs and was there an associated decrease?
No, unfortunately, as I was trying to sort of explain earlier, we didn't have the chance to look at HAIs because these hospitals do not track, they don't do blood cultures. So there was no way to really say this is definitely a healthcare associated infection or not. Um, so I would say our outcome is a good outcome, but it would be great to be able to scale this up and say, this definitely reduced healthcare associated infections. There are definitely trials from high-income countries, like the Clean trial from Australia, that kind of shows that pathway. So I think we know etiologically that that can happen, but we couldn't show it here. Yeah.
I'm going to sneak in a related question. Did you have access to any health records data like HMIS that you were able to integrate into your findings or no?
You wouldn't be able to do
Mm.
this. You would need much more granular data, unfortunately. We did think about it, but it's not good enough. Yeah, you have it. Yeah,
Good.
it's not good enough. I mean, there may be one hospital where we might be able to actually look at HAIs, more granularity.
Mhm.
But again, it, there is with I don't know how many people like how many of you have engaged with diagnosis of healthcare associated infection is not as trivial as some other conditions because you need both the sort of symptomatic diagnosis but also blood culture proof, and otherwise you end up having a lot of misclassification, so it's a bit tricky, especially if you want to try and establish causal inference. So yeah.
Great. Evelyn's got a really interesting question. Did you experience cleaning staff turnover in either the Tanzania or Cambodia study? And if yes, did this have an effect on the study?
Yeah, fantastic question. Yes, there is turnover. There is always turnover of this type of stuff because, again, usually they don't have great contracts. So if they find something better. Another issue that often comes up is the contracted out arrangements, which means that the hospital per se has very little accountability, and the management is done by other companies. And this happens not just in low resort settings, it also happens in the UK, happens in other high income countries. So often it's something that needs to be figured out in the needs assessment moment. When you're trying to implement this program, you have the needs assessment moment when you're trying to figure out what are the resources, what are the current training standards, do you have contracted out staff and how can we reach them and can we feasibly reach them? And another thing we've done when we were a bit stuck was also task shifting. So in some cases, you need to think, who's actually doing cleaning of what. In some hospitals, you have the beds are done by the nurses, the floors are done by the cleaners. And sometimes if cadres are stretched, you can think of task shifting. There are great example, for example, of mothers of babies being engaged in pediatric ward cleaning. I'm not advocating for patients to be doing any of this, but I'm saying in very difficult circumstances, you can definitely think of task shifting towards some of the carers. You can think about task shifting from cleaners to nurses or nurses to cleaners. And I think you need to be creative when, like as usual, when resources are limited. But yeah, unfortunately, it is an issue, both turnovers and contracted out stuff.
Great. Another question, did hospital leadership influence practice and results? Did you include hospital leadership in the training?
So the idea for this type of training program, the first sort of one of the things you do to sort of even initiate a needs assessment at the beginning of this program is to engage the hospital leadership. I wouldn't say there is any formal training for leaders in this case, but there is definitely that first point of contact, unless the hospital leadership thinks, yes, this is something I want my staff to be released for 5 days and conduct the training. Obviously, you cannot move any further. But as mentioned earlier, I think there is still a huge gap in most hospital leadership in understanding the importance of both cleaners and environmental hygiene. And I think we're getting better, but there is a lot still to do. And unfortunately, I think there are not many. It's still ad hoc and it's still down to the hospital manager whether they want to be as engaged or not as engaged. And I mean, I think we can learn a lot from other areas in health. This is not a specific issue just with environmental cleaning. It's an issue of how you conduct your budget, how you understand your priority setting. And I think it's not something we need to reinvent the wheel on. I think we can learn from other areas in health.
Yeah. Matthew asked, is there any difference between cleaning, disinfecting, and sanitizing, and which one is most appropriate for each type of hospital?
Yes, so I'm not going to go into that because that's a whole world of definition and terminology. There is actually a group who's currently doing a dictionary on this, but it's not about necessarily the type of hospital, but a type of activity you do, and a type of disease and type of whether it's body fluids or not that you're dealing with. So there is some guidance in the training on these different things. Usually, most definition is high risk area, low risk area, and this is something that usually the facility would need to decide on. This is high risk area, this is not a high risk area, but it's based on disease etiology, where the body fluids are involved, and so on. But yeah, it's a whole world in its own.
Okay. Any final questions? Oops. Stop. All right. Well, thank you so much, Georgia, for your excellent presentation. Thanks, everyone, for the great questions. And yeah, thanks, everyone, for joining. And please make sure to register for the WHO UNICEF webinar. And stay tuned if you'd like to rewatch this presentation. It'll be posted to YouTube shortly. And yeah, we'll look forward to seeing you all next month. Thanks again, Georgia. To see you all soon.
Thank you, everybody.
Bye.
Bye.